Thanks ever so much for asking me to come and speak to you all. I'm just going to forward the slides. I hope everyone can hear me. And I hope you all made it through the trains and the cricket and everything else that was holding us all up. But the title of my talk, so I'm a GP and a specialty doctor in dermatology in Gloucestershire. The slide on the top right is the magnificent Gloucester Cathedral. If you've never been, you should definitely come. That's where part of the Harry Potter movie was filmed. And I also do a little bit of teaching for the University of Hertfordshire on some of their dermatology modules. And I'm really grateful to the Psoriasis Association for giving me the opportunity to talk to you about what we know about psoriasis and treatments that are available in primary care. I've titled the slide Not Just Skin Deep because we do know that psoriasis affects far more than just the skin. So what is psoriasis? Well, it is a long-term relapsing immune condition and it can affect any area of the skin, including scalp, nails, genitals and feet. And in up to a quarter of people, they can develop a type of arthritis called psoriatic arthritis. We know it can have a significant effect on mental health and social well-being. And in people with moderate to severe psoriasis, there is an increased risk of heart disease and strokes. And it can also rarely be associated with some types of inflammatory bowel disease, such as Crohn's and ulcerative colitis, and uveitis, which is a type of eye inflammation. The prevalence of psoriasis is around 2.5%, which equates to around 1.8 million people in the UK. Male and females are equally affected, and it can occur at any age, but there are generally two peaks, one between sort of mid to late teens through to mid-20s, and again between 50 and 60 years of age. In normal skin, the turnover is takes about 3 to 4 weeks for your skin to turn over. But in psoriasis, that process is massively accelerated, only taking 3 to 7 days. And this is what causes the accumulation of cells which build up to form those scaly plaques on the skin. It's really important that people understand this is not a contagious condition. It's not associated with poor hygiene. It doesn't scar, but it can cause short-term lightening or darkening of the skin, and it comes and goes unpredictably. It's not fully understood what causes psoriasis, but we know that there are inherited, known as genetic, and environmental factors. It's an immune condition with activation of immune cells which then produce inflammatory chemicals causing rapid growth of skin cells. There's often a positive family history, so people in their family previous other family members may be have had the condition. And we know there's a number of triggers for setting the disease off, but also causing flare-ups, such as smoking, alcohol, stress, trauma to the skin, drugs, infections, and hormonal changes. So what does psoriasis look and feel like? Well, it can be itchy, but not always. The most common type is something called chronic plaque psoriasis, and that's the most common type by far. But there are a number of other variants, which I'm going to talk about in a little bit of detail later, but they're listed here. So this talk is all about primary care and what we can offer you in primary care if you're suffering from psoriasis. And this slide is a screenshot of the Primary Care Dermatology Society psoriasis treatment pathway. And I think it illustrates really, really well that treatments in primary care, and in fact just generally, but definitely for us in primary care, are tailored not only they're tailored to the site of the body, the type of psoriasis, but also patients' preferences around treatments. And there's quite a few different options, so it's not completely straightforward. It's not a one-size-fits-all. Now, psoriasis is usually a clinical diagnosis, so we can see it on the skin, but it's far more than that. We need in primary care to be doing a lot more for people who are suffering with psoriasis. We need to take that holistic approach, and it's really important that we do the following steps, including assessing how it's affecting someone's mental and social well-being. What treatments are they using or have they tried, and how effective are they and how easy are they for them to use? We ask about those trigger and exacerbating factors that I talked about before and assess them for their comorbidities. So that's asking them, are you having any problems with your joints? Are you having any gastrointestinal symptoms? And importantly, for people with more severe end of the spectrum, we need to do a formal risk assessment for cardiovascular disease, which is checking blood pressure, cholesterol, and that kind of blood tests. And that's recommended at least every 5 years in adults. We really do need to explore with people their expectations of treatment and what are their own treatment goals. Some people are wanting their skin completely clear. Other people are just wanting to be able to undertake their daily activities like going swimming, that kind of thing. We need to examine the skin, which we would do in full ideally, for looking at the areas that are affected and also how severe the disease is. We always need to look in the scalp and look at their nails, which can be affected. And we really do need to ask about whether there's any genital involvement. This is a difficult area and that people may not volunteer it because it's a sensitive subject, but it is important to know if there is any involvement in that area of the skin. So treatments, we know there's no cure, but let's be positive. We can manage this condition very well if people are given the right information and support. And a lot of patients are seen and treated in primary care and don't end up going to secondary care. But we need to tailor the treatments, as I said, to the type of psoriasis, the body site, and individual preferences. It can be a process of trial and error, and people need to be aware that treatments do take several weeks to become effective, so they're not going to work necessarily within a week or two. The treatments in primary care are all topical. In other words, they're applied directly to the skin and scalp, and they have different active ingredients. It's really important that we enable patients to be able to access their treatments on repeat prescription if needed. And for some people, they're on quite a number of different treatments, and it can get quite expensive with the payments for prescriptions if you pay for your prescriptions. And it's worth just noting that you can get a prepayment certificate, which can minimise the costs over the course of a year. So when we are supporting our patients who suffer with psoriasis, for me, it's really vital that we are giving them sufficient education, lifestyle advice, and psychological support. We need to try and support people with managing their risk factors for heart disease and stroke, adopting that healthy lifestyle, losing weight if you're overweight. Now, actually, it has been shown that losing weight and exercise in people who are overweight can actually reduce the severity of their psoriasis as well as improving their quality of life. We need to support them with stopping smoking and reducing alcohol intake where needed, reducing stress where possible. And people do really struggle with the psychological and social well-being with this condition, and we need to offer them support and referral to appropriate psychological therapies if needed. And again, I keep coming back to it, but really talking to people about what are their concerns and preferences around treatments. And very important, the final point, to refer people to that high quality supportive information. And this is to improve awareness, but really also people to become more confident in self-managing their condition, because it's a long-term condition that comes and goes. So this slide is all around the different sources of support and information. The Psoriasis Association has a brilliant website, really so much information on there, it's amazing. And then there's other organisations as well, the Psoriasis and Psoriatic Arthritis Alliance. The Primary Care Dermatology has patient information leaflets, as does the British Association of Dermatologists. There's brilliant videos as well from the British Association of Dermatologists on things like how to use moisturisers, topical steroids, and there's a really good one for treating scalp psoriasis. There's also a psoriasis decision aid that I've linked to on this slide, and that's to help people, that individualisation of treatment. It's a really good little tool to be able to, and it's freely available. So if these slides are available afterwards, I'm sure people can look at that. So whenever we start someone on an active treatment for their psoriasis, it's recommended that they are followed up by their GP 4 to 6 weeks after treatment starts to see how they're getting on with the treatment, how effective it is, and how easy is it for them to use. But people will often say, when should I expect a referral to dermatology? I think I'm just going to run through with you the kinds of things we are thinking about when we see people with psoriasis. There's the sort of urgent, immediate patients. These are rare. We don't see very many of these at all. In fact, I'm not even sure I've ever seen anyone that I've had to admit urgently that day. But it is for people with things like erythroderma, which is where large areas of the skin are covered. Generalized pustular psoriasis is another, can be a very serious condition, and in unwell people where the psoriasis is rapidly worsening. That's a sort of on the day, phone up the dermatologist. But there and lots of other times when we will refer to dermatology, and this list here is just to run through that. When we're not sure about the diagnosis, if the disease is severe or extensive or not responding well to the topical treatments that we've initiated, or if the patient can't tolerate those treatments, if they're having the psoriasis is having a significant impact on their mental and social well-being. And some of the sites on the body are much harder to treat, like the nails and sometimes the genital areas. So we would potentially refer those people suffering those kind of areas sooner than others. People with joint symptoms, so swelling or pain in their joints with suspected psoriatic arthritis, they're referred urgently to rheumatologists. So sometimes people are seeing both a rheumatologist and a dermatologist. And it is recommended that you are reviewed with your GP annually to check things and how you're getting on with treatments and if you've got any questions, and doing that screening for those comorbidities that I mentioned. So psoriasis in children, I just thought I would talk a little bit about this because it does occur. It's less common. It can have a different appearance to adult onset psoriasis, and the diagnosis may only become clear over time. The scalp is the most frequent site of onset. We need to think about it in any child with a persistent rash in the sort of nappy area that involves the skin folds. They may get redness and scale around the ears and or around the tummy button, the umbilicus. Guttate psoriasis, which is a specific type of psoriasis, is much more common in childhood and teenage years. And there'll often be a family history, as there is for anyone with psoriasis. We talked about the information and support really being absolutely essential for people suffering with this condition, because it's it can be such a long-term condition. Now, the Psoriasis Association has some brilliant it's a brilliant website. It's got a helpline, which I'm sure many of you are aware of, which is available Monday to Friday. I really love the fact that it's got a part of their website is for unavailable treatments. I thought I'd bring this up here because we frequently have problems with treatments going in and out of stock, sometimes temporarily, sometimes long-term discontinued. So if people are not sure, they can go to this area of the website and check if their treatment is available or not due to manufacturing or Brexit, or I don't know what issues there are, but often we do find that there are problems. We should always be able to signpost people or either refer directly or allow people to self-refer for mental and psychological support therapies. And the NHS talking therapies is available in every area of I think it's in England, I'm not sure about the whole of the UK, for anyone over the age of 18. And then the forums on the Psoriasis Association, I think this is absolutely vital for people who suffer with this condition, because it enables that peer-to-peer support that we can't give if we haven't lived with the condition. So that's another area I would encourage people to look at if they haven't already. So coming back to treatments again, so once we've started an active treatment, it's really important that we check the response to treatment, as well as acceptability, tolerance, ease and use of those treatments. And I've been through this slide, I think, already, so I'm not going to go through it again. So this was the most common type. I wanted to just run through the different types. So chronic plaque psoriasis is this condition where you get these slightly raised pink-red plaques with silvery white surface scale. It's important to note that people with skin of colour, the plaques will be much darker and may have sort of grey scales. So I haven't got any really good photos, but that's worth noting. And they can be large or small, the plaques. They're commonly on the backs of the knees, elbows, on the trunk, around the scalp, ears and between the buttocks. Scalp psoriasis is really difficult for people. I think this is an area where people really do struggle. The treatments are difficult. It can be quite messy and time-consuming, and it's socially difficult for people. But essentially, it's common for plaque psoriasis to affect the scalp. They get build up of scaly skin, causing dandruff-like flakes. Typically extends just beyond the hairline, around the ears, behind the ears. And you may be itchy and have a sort of tight sensation on the scalp. People often worry about losing their hair. It can cause, in severe cases, thinning of the hair, but we need to reassure people this is temporary and it will return when the psoriasis has been adequately treated. Nail psoriasis. This affects up to 50% of people with psoriasis, much higher in people who have associated psoriatic arthritis, and they'll get these little pits in the nail, which is seen as little dents on the nail surface. They'll get lifting of the nail plate, which is called onycholysis. You may get thickening and yellowing of the nails, a pink discoloration, and often the changes are seen in the nails of both hands, and it can coexist with sort of fungal nail infections. Inverse or flexural psoriasis, as it's otherwise known, this is where we get sore, shiny red patches, again, darker on darker skin tones. They don't have a typical scale that you get with plaque psoriasis. They often affect the armpits, the groin, and under the breasts, and they can coexist with people suffering with chronic, so you can get more than one type of psoriasis on the body at the same time. And they can be either coexisting or mistaken for fungal skin infection. So guttate psoriasis. This is a variant of psoriasis, and guttate is the Latin word for drop. And in this variant, you get these small, scaly, sort of teardrop-like or raindrop lesions on the torso and on the limbs most commonly. It's much commoner in children and young adults, and it's often triggered by a bacterial throat infection. It usually fades over a few months, but it can recur. And a third of people will go on to develop chronic plaque psoriasis after having had guttate psoriasis. Palmar-plantar pustular psoriasis is a rarer type of psoriasis, and this is where we get these painful, small yellow and brown spots on the soles of the feet and sometimes on the palms of the hands. The fluid in the spots, it's important to say, is not infectious, it's not contagious, and it's much more common, this type of psoriasis, in people who smoke. Hyperkeratotic palmar-plantar, this is where we get a variant where you get very thick and scaly plaques on the soles of the feet and sometimes the palms of the hands. Again, it can either coexist or mimic fungal foot infections, and sometimes it can be difficult to distinguish it between from eczema. There's a type of contact eczema that people can get, so it can be difficult to tease out what's what, but you'll be looking for other areas of the skin affected as well. So I've run through this slide and this slide. Those are the other rarer variants of psoriasis. And I've been through the slide on psoriasis in children, so I do apologise. It's all a bit topsy-turvy. Right, so getting on to the treatments. So topical treatments, that's what we can use in primary care and advise people to use. So the number one thing is moisturisers, and I know and they're using soap-free washes, and I think there's a talk later on a bit more about using topical treatments. But moisturisers are really important because they reduce the scale and make the skin more comfortable. It's important to stress that it needs to be a fragrance-free moisturiser, and not things with loads of different additives that can irritate the skin. They can allow the other active treatments to be better absorbed and work more effectively. And there's lots of different formulations and consistencies to choose from, right from lotions, which sort of are lighter and thinner, right through to ointments, which are thicker and greasy. And the best moisturiser is the one the person feels happiest using. So it can be a process of trial and error with those. And generally, we advise to apply twice daily. I mean, more if you can, but in pragmatic terms, at least twice daily, and then about half an hour before any of the active treatments. Now, moisturisers can be all bought over the counter, but it's important to tell people that they are, when you've got psoriasis, it's a long-term skin condition, you are entitled to your moisturisers to be available via your GP on prescription. So then we're talking about the active topical treatments. These have different active ingredients, and they're generally only available on prescription. And these are the ones that act to modify that immune response and prevent the excessive growth of skin. So we're talking about topical steroids, topical vitamin D preparations, coal tar and calcineurin inhibitors are the main ones. And again, coming back to what I said earlier, we have to choose it according to where the psoriasis is, what type it is, and patient preference. And sometimes we do need to use a combination of treatments. It takes a few weeks, like I said, to become fully effective, and it's important that we do review people 4 to 6 weeks, or in children sooner after starting treatment. And one other message that I think is really important is that treated skin often does have a slight darkening of skin colour. That will fade slowly, and it doesn't need to be ongoingly active treatment ongoingly applied to the skin once it's flattened, even if there's still a discoloration on the skin. So vitamin D preparations, this is one of the major type of treatment that's available. There's 4 different treatments in the UK, different preparations again. And in terms for chronic plaque psoriasis, certainly the combination of using a topical steroid with a vitamin D, so these will be products you may well be familiar with, Dovabet, Enstellar, and a new cream called Wynzora cream. This is our first line for chronic plaque psoriasis because it's more effective at gaining faster improvements. You should apply it once a day until the lesions are flattened, or for a maximum of 4 weeks daily use. And then once the psoriasis is improved, you can use either ongoing maintenance treatment with either just Dovanex, which is just a vitamin D on its own without a steroid, or using that combination treatment sort of twice a week. So the picture on this slide is Enstellar foam. That's a really nice product that a lot of people do really like using, and it has got a license for maintenance treatment. They're applied about half an hour after moisturising. They can affect the way the body absorbs calcium, so we have to be careful in people with calcium disorders. Women who are pregnant or breastfeeding, very careful. If you've got severe liver or kidney disease, we have to be cautious about prescribing these. What's good is they don't smell and then don't stain the skin, but we need to tell people they can cause local skin irritation on sensitive skin sites, so sort of skin folds and around the face. And there is a maximum amount that can be issued each week due to that fact that it can affect the calcium levels in the body. So topical steroids, these are, again, used in lots of different conditions, but specifically for psoriasis, we do use them to reduce that skin inflammation. There's lots of different strengths, from mild right through to very strong, and there's, again, lots of different formulations. They're often used in combination with the vitamin D products, and again, it's applied after moisturising, leaving a bit of a gap. We often use these for treating sensitive skin sites, so face, some of the genital areas, skin folds, and we need to use a mild strength steroid for a shorter time, in this case, to reduce the risk of any side effects, such as thinning of the skin or excessive hair growth. Again, that's very unlikely to happen if it's used appropriately and with the correct instructions. And the very important message with steroids and psoriasis is we must wean off them slowly, because if you stop them straight away, they can cause rebound. You may get a rebound of the psoriasis, which then can get worse. So that's a very important message. So tar preparations, coal tar, this is the oldest known treatment for psoriasis. It's been around for a long, long time, like really a long time. And there used to be these thick, heavy oils, which were quite smelly and messy. But nowadays, the modern treatments are a lot more cosmetically acceptable. And again, they're often combined with other active topical treatments. So lots of different formulations, and they're not quite as effective as the vitamin D and topical steroid combined treatments. But the really good thing is they can be used on both affected and unaffected skin. So, for example, we would often potentially advise someone to use Exorex lotion if you've got guttate psoriasis, because that's lots of small, very tiny spots. It's not practical to be applying to each individual spot. So you can just smooth the Exorex lotion over the whole affected area and not worry about the risk to the unaffected skin. They can stain clothing and skin, so you need to tell people about that, and can cause sunburn reactions, so sun sensitivity. again, need to tell people about that, and they can cause skin irritation on those kind of sensitive skin sites, so we need to be telling people about that. So topical calcineurin inhibitors, these are a class of topical treatments that are used in what we call off-license. So they're not licensed for use in psoriasis, but they are very, very commonly used, as they are in other long-term inflammatory skin conditions. They block a chemical called calcineurin, which is one of the chemicals that's switching on that inflammation process, and they work to reduce the inflammation. Unlike topical steroids, they don't cause any skin thinning, so they're very useful for sensitive areas where the skin is thinner, such as the face, under the arms, the genitals and skin folds. There's two different types available, Protopic and Elidel are the trade names, which you may have come across, and they're usually put on twice a day. Can't use them in pregnancy, breastfeeding or on infected skin, and it's key to tell people at the beginning that when they first start using them, they will get an initial kind of burning or prickling sensation on the skin. That is normal and it will settle over a few days. They can get facial flushing with alcohol and increased sun sensitivity. So again, we just need to make sure people are aware of that. Topical salicylic acid. This is a very useful agent because when people have very thick plaques on the skin, the active treatments struggle to penetrate and then aren't as effective. So we use the salicylic acid. It's like a descaling agent. It helps to reduce that excessive scale, and it's useful on these thickened plaques on the body, but also on the scalp particularly, and it's often in combination with other topical treatments, so you either use it alongside or before you put on the active topical treatments. It can sometimes cause skin irritation on the surrounding skin, so we just have to be careful. Topical dithranol, I'm not really going to talk about because it's not really available for us as on prescription anymore, or made for supply in general pharmacy. So it's a sort of older treatment that isn't really available to us in primary care anymore, but just to mention it in case any of you have come across that or been advised to use it. My last two slides are around just these difficult to treat sites. Scalp psoriasis, we often have to use a combination of treatments, and it's messy and it takes up time, and I think it's really important that people are given the right information right from the get-go of when they need to start treating their scalp. And there's some brilliant resources. One is the British Association Dermatology video guide, just goes through, step by step how to treat your scalp psoriasis. And then the Psoriasis Association have got a brilliant leaflet on their website as well, so I'd encourage anyone to look at that. Nail psoriasis, it's a cosmetically sensitive area. People are often asking about treatments. I have to set people's expectations because it's very difficult to manage nail psoriasis, and particularly in primary care, we've got very little to offer. We talk about keeping nails short. They can use nail varnish. There's no problems with that in women who want to use nail varnish. We need to just rule out any fungal nail infection and treat that if there is any coexisting infection. And then people can try something like Doverbet gel as a trial on the nails for once a day for 3 months, but it's generally quite ineffective on nail psoriasis. And if it's very extensive or severe, they can be referred to secondary care. And we just, again, need to be aware, if we've seen lots of nail changes, ask that all-important question, are you having any problems with your joints? Because it is strongly associated with psoriatic arthritis. So thank you, and I'm sorry about the juggle with the slides.